So now we'll do cancers of the lungs. Epidemiology. It is the second most common cancer. Second most common cancer, leading cause of cancer death, peak age 65 to 75, more prominent in men except adenocarcinoma, which is more prominent in women. Risk factors of lung cancer is tobacco smoking, weaker association in adenocarcinoma. So people who have lung adenocarcinoma, they're less likely because of tobacco smoking. Okay, radon. Radon will also do it. Asbestos, arsenic, chromium, nickel, beryllium, and silica. Genetic predisposition, pulmonary scarring, radiation, fibrosis, tuberculosis, and HIV are all risk factors for lung cancer. Now, clinical manifestation of lung cancer is cough, hemoptysis, progressive dyspnea, wheezing, weight loss, fever, weakness, superior vena cava syndrome, where there is venous congestion of the head, neck, and upper extremities, paralysis of recurrent laryngeal nerve, causes hoarseness in the sound, dyspnea, diaphragmatic elevation, phrenic paralysis, and you have malignant pleural effusion and post-obstructive pneumonia. Malignant metastatic disease will go to either brain, liver, adrenal gland, bone. Brain, liver, adrenal gland, bone. For the brain, you will have headache, seizure, focal motor deficits, nausea, jaundice, and ascites for liver. Elevated serum alkaline phosphatase and calcium in the bone. If you have a malignant metastatic disease from the lungs. Okay. Now, paraneoplastic syndromes of lung cancer, if it is a non-small cell lung cancer, it will cause cachexia, okay, underlying illness causing muscle loss. There will be muscle loss because of non-small cell lung cancer, thrombocytosis, and disseminated intravascular coagulation, DIC. Hypercoagulability increases risk with adenocarcinoma, dermatocytosis, hypercalcemia of malignancy, hypertrophic osteoarthropathy, clubbing of fingers and toes, just swelling, clubbing of fingers and toes, very important, swelling and pain in joints. Okay, now small cell lung cancer, you will have Cushing's syndrome, SIADH, paraneoplastic cerebellar degeneration, peripheral neuropathy. How do you stage lung cancer? Tumor, lymph node, metastasis. Now, based on the size, ipsilateral hilar or peribronchial lymph node, contralateral lymph node or supraclavicular lymph node. Okay, first it will happen in these lymph nodes, and then it will go to the contralateral lymph node and the supraclavicular lymph node. Metastasis, pleural metastasis for pleural membrane, and single extrathoracic metastasis. Okay. Prognosis is extremely poor with a 5-year survival rate is below 20%. Clinical manifestation is based on therapy. So, for small cell carcinoma, the systemic therapy is surgery, rarely possible, reacts well to chemo. Prognosis is poor. Non-small cell carcinoma treated well with surgery, prognosis is better than small cell carcinoma. Better than small cell carcinoma. Pathologic classification is squamous cell carcinoma, adenocarcinoma, large cell carcinoma, and neuroendocrine carcinoma, and mixed giant cell and annuity of salivary type. Squamous cell carcinoma used to be the most common, but adenocarcinoma is now becoming the most common. Macroscopically, most tumors, especially squamous cell carcinoma, are seen along the major bronchi and central area of the lung. Okay, major bronchi in the central area of the lung. Adenocarcinomas tend to be situated more in the periphery. Okay, cancer spread to the pleural surface, pleural effusion. Okay, extension of cancer to the lung apex is Pancoast tumor, presents as Horner syndrome. Compensation of mediastinal structures is by superior vena cava syndrome. Metastasis first to mediastinal lymph node, late metastasis to liver, brain, bone, skin, and I think adrenal glands as well. Yeah, even adrenal glands. Okay. Therapy, surgery, lobectomy, chemotherapy, radiation, targeted therapy, tyrosine kinase inhibitors for adenocarcinoma, endothelial growth factor receptor, and ALK and ROS1 inhibitors, I think. And then immunotherapy checkpoint, nivolumab, pembrolizumab, and overexpressing PDL1. Immune checkpoint inhibitors. Cancer is normally infiltrated by lymphocytes and NK cells, which tends to be inactive. Immune checkpoint inhibitor blockers the function of PD1 and PD2 and CTLA4, activation of residing T cells, and immune reaction against cancer. Blockers, the function of, they are basically trying to activate the inactive T cells. Okay, immune reaction against to produce an immune reaction against the cancer cells. Clinically approved inhibitors of PD1, PDL1, and CTLA4 is nivolumab, pembrolizumab, atezolizumab, and avelumab, and ipilimumab. Types: you have small cell carcinoma, squamous cell carcinoma, adenocarcinoma, large cell carcinoma, mesothelioma, carcinoid, and paraneoplastic syndromes. For small cell carcinoma, it is an aggressive neoplasm with neuroendocrine differentiation, centrally located with rapid growth and high metastatic potential, small round blue cells with absence of nucleoli. Azopardy phenomena is a basophilic coloration. The basophilic coloration of the blood vessel wall from disintegrated DNA, and it is more prominent in men than females. 70% of the patients get this type of carcinoma. It has a saltpeter chromatin. Now, squamous cell carcinoma is an invasive carcinoma, more frequent in male smokers. A damage of bronchial epithelium by tobacco causes dysplasia. Majority of the central parts of the lung, main or segmental, as well as 10% at the periphery. Rigid nodule with white grayish color that is sometimes ulcerated. Spread within the bronchial wall into the adjacent parenchyma, necrotic disintegration, Jonas caverna. Solid sheets with large eosinophilic cytoplasm, nuclear and cellular polymorphism with nuclear atypia, prominent nucleolus, rough chromatin. Well differentiated cancer causes keratinization. Okay. Adenocarcinoma is rising in incidence, 1/3 of all lung cancer, mostly in women, not linked to smoking. Grows slowly but metastasizes early than squamous cell carcinoma. Precursor lesions are atypical adenomatous hyperplasia and adenocarcinoma in situ. Histological types are glandular, papillary, solid, lepidic, mucinous, enteric. These are the different glandular structures in adenocarcinoma of the lung. If the mutation is certain genes, therapy is EGFR, ALK, and ROS1. Macroscopically, it is a solitary or multiple white grayish nodules, mostly peripheral. Central endobronchial tumors can also be present. Diffuse pneumonia-like is rigid consolidated lobule. Microscopically, the tumor's cells resemble ciliated elements in goblet cells, bronchial gland cells, and cells of Clara. Okay. At the periphery, there is a frequent bronchoalveolar spread. Large cell carcinoma is purely differentiated carcinoma, has bad prognosis. Diagnosis is difficult but does not express markers of glandular squamous or neuroendocrine differentiation. Mesothelioma is not a carcinoma, arises from the mesothelium. Carcinomas are the ones that arise from the epithelium. Strongly linked to asbestos exposure and has poor prognosis, very poor prognosis. Most patients are men. Pleural mesothelioma is most common. Peritoneal and pericardial are rare. Clinical manifestation is chest pain, shortness of breath, cough, wheezing, hemoptysis, and fatigue. Causes is ascites. Late lesions metastasize locally aggressive. Diagnosis is suspected in older individuals with unexpected chronic pleural or peritoneal effusions. Chest X-ray and CT, bioptic and cytologic verification needed. Treatment and prognosis: highly resistant to chemotherapy and radiotherapy, not movable completely by surgery, can't remove it by surgery. Pleurectomy and extrapleural pneumectomy. Okay, multimodal therapy, poor prognosis. Macroscopically glows along the serosal membrane, whitish form, infiltration into the lungs, chest wall, and mediastinal organs. Cytologic findings: staining sample has HE or KEMSA. Cells are large and big, atypical vesicular nuclei. Microscopically, mesothelioma is not carcinoma or sarcoma. Epithelioid mesothelioma is close to adenocarcinoma. It has tubular, papillary, and trabecular or insular structure. You have sarcomatoid mesothelioma, looks like sarcoma, and it's made up of spindle cells arranged into fascicles. Most of the tumors have desmoplastic stroma. Carcinoid is a neuroendocrine neoplasm originating from the pluripotent cell of the basal cell of respiratory epithelium. 2 to 5% of the lung neoplasms are carcinoid. No sex predilection. Rare ectopic production of ACTH, as it happens in Cushing's, and carcinoid syndrome, serotonin 1%. Macroscopically, 2/3 is central, 1/3 is peripheral. 2/3 is usually endobronchial component, smooth polypoid mass protruding into the bronchial lumen and covered with intact mucosa. But 1/3 that is peripheral is a solid nodular foci. Okay. Microscopically, it nests palisading or ribbons with uniform cytology. Typical carcinoid is increased mitotic activity, necrosis, areas of higher cellularity, and disorganized architecture. Paraneoplastic syndromes: 1 to 10% of lung tumors have increased hormones and peptides. Paraneoplastic syndrome 1 is ADH increased hyponatremia. ACTH Cushing's, PTH and PTHP hypercalcemia, calcitonin hypocalcemia, gonadotrophins gynecomastia, serotonin bradykinin carcinoid syndrome. Paraneoplastic 2, the patient might have leukematoid reaction, Horner's triad, which has 3 things: meiosis, and encephalomatous, and ptosis. And here we finish lung cancer.